Everyone. I'm Dr. Sriramadesigan, Assistant Professor, Department of Psychiatry, Lakshmana Institute of Medical Sciences, Puducherry. Today, this topic is sleeping disorder. So, what do you mean by sleep? Sleep is a regularly recurring, rapidly reversible neurobehavioral state characterized by designs, postural recompense, and reduced awareness of the environment. Reduced awareness means there is no absence of awareness, but only reduction in awareness about the environment. So, neurobiology of sleep has various stages. One is wakefulness, sleep initiation, NREM sleep, and REM sleep. So, in wakefulness, the brain region involved are lateral hypothalamus, brainstem arousal centers are locus coeruleus, raphe nucleus, pedunculopontine, and laterodorsal tegmentum, ventrotegmental area, posterior hypothalamus. In sleep initiation, the brain region involved are anterior hypothalamus, that is ventrotemporal preoptic area, and that is also known as VLPO, and median preoptic nucleus, that is MNPO. So in NRM sleep, the brain region involved are VLPO, MNPO, which has an inhibition of arousal centers, and locus coeruleus and raphe nucleus our activity decreases. In REM sleep, where the brain region involved are LDDP and PPT activation, that is cholinergic, and locus coeruleus and raphe nucleus are inhibited. So there are in sleep, the light and dark cycles plays a vital role. If light directed by retina in is sent to the signal to retinohypothalamic tract through suprachiasmatic nucleus is activated, and suprachiasmatic nucleus sends inhibitor signals to the pineal gland, and melatonin secretion is inhibited, and which makes his body alertness increases and wakefulness is promoted. During darkness, the darkness is directed by the retina, reduce signal transmission to suprachiasmatic nucleus, and suprachiasmatic nucleus sends stimulatory signals to the pineal gland via sympathetic pathways. So, which in turn, the superior cervical ganglionic plays a role in transmitting these signals, and which increases the melatonin secretion and induces sleepiness. So, there are a physiology of sleep. One is two physiologic states, that is REM and NREM. That one NREM has four stages: stage 1, stage 2, stage 3, and stage 4. The sleep is measured by a polysomnography simultaneously, which is a simultaneous measurement of brain activity by EEG, eye movement, and muscle tone. Typically scored in epoch of 30 seconds with the above three parameters. Usually it is measured in epoches, which is long for around 30 seconds. So this is the sleep wave measurements. So in each wave, in relaxed to wakefulness, there is majorly alpha waves. In stage N1, that is mostly we see theta waves. In stage N2, sleep spindles are seen and K complex are seen. K complex, the highest peak point, that is seen in stage N2. That is, then in stage N3, we see delta waves. In REM this is the pattern we see in REM sleep. Okay. So these are the wakefulness mainly alpha, that is 8 to 13 hertz, and beta activity of more than 13 hertz on EEG is seen. In NREM sleep, there is N1, formerly stage 1, slow theta waves of 4 to 7 hertz emerges on EEG. That during that wave there is a rolling eye movements is seen in slightest stage of sleep, and N2 is stage formerly known as stage 2. Background theta waves less than 20% delta waves are seen, sleep spindles, and K complex. These are the K complex, which has high amplitude central sharp waves on EEG. So eye movements usually cease during stage 2. The eye movement usually ceases, but in stage 1 only we see lightest rolling eye movements is seen. But the lightest stage of sleep is N1. Okay. N3, eye amplitude delta waves less than 4 hours on EEG, also termed as slow wave sleep. Eye movements are slow or absent. It is a deepest stage of sleep. So next comes REM sleep. REM sleep is 20% of the sleep time occupies the REM sleep. Low voltage, mixed frequency background on EEG, static eye movements, 80% of the dream occurs in this stage. This may be recalled easily, especially if immediate awakening after dream onset. Usually, or most of the dreams occurs in REM sleep, but they also have ability to recall the dream happening in REM sleep. There are stages of sleep. One is sleep latency. It takes 15 to 20 minutes. What is sleep latency? Sleep latency is the period of between going to bed and getting the sleep. That is sleep latency. Initial sleep latency is 15 to 20 minutes. Next is 45 minutes. That after a sleep, next 45 minutes after stage 1 and stage 2 of NREM. That is the and stage 3 and 4 is the deepest sleep. So after 45 minutes, stage 4 begins first REM sleep. On onset is 90 minutes. Okay. As night progresses, REM becomes longer. So after a time period of sleep, the REM sleep becomes longer. Stage 3 and stage 4 usually disappears. So these are the brain activity features of REM and NREM sleep. Brain activity highly desynchronized in REM and low synchronized in NREM. Eye movement, rapid darting movements is usually seen in REM sleep, and in NREM, eye movement is slow or absent. Muscle activity is paralysis, that is atonia, seen in REM sleep, and reduced tone usually seen in NREM sleep. Dreaming, vivid and story-like dream comes in REM sleep. Minimal and thought-like dreams usually comes in NREM sleep. Heart rate and BP irregular and elevated in REM sleep. In NREM, it is regulated and decreased. Respiration usually irregular and shallow in REM sleep. In NREM, regular and deep. So in sleep stages, single stage, that is 20 to 25% of sleeps divided into in REM NREM divided into N1 light, N2 and N3 deep. Purpose, emotional and memory consolidation in REM sleep, physical restoration and immune function in NREM sleep. Usually the purpose of REM sleep is to emotional and memory consolidation. In NREM, that is physical restoration of the body and increases in human function usually happens in NREM sleep. Physiological effects of sleep deprivation. If people starts to decrease degrees of sleep time, these are the factors affecting day-to-day activities. That is initial sleep deprivations has both physiological and psychological effects on all human beings. So if sleep deprivation starts, physiological effects are that occurs in our body are increase in catecholamines, increased secretion of ACTH and cortisol. This in turn has short-term consequences like increase in stress, somatic problems and psychosocial issues. So it also then the sleep deprivation also interrupts the circadian rhythm disrupted, which also in turn short-term consequences on stress, somatic problems, psychosocial issues, long-term consequences of cardiovascular disease, obesity, type 2 DM, cancer, and death. Okay, and sleep deprivation also has action on insulin reduction in insulin sensitivity, decreased leptins, increased ghrelin, and increased appetite. And oxygen consumption is increased, and CO2 production is also increased. So, and it also has an upregulation of TNF, IL-1, interleukin-1, interleukin-6, and CRP, and also reactive oxygen species, and also as it leads to decreased production of melatonin production. These are as a short-term consequences on and long-term consequences. Short-terms are somatic problems which we previously seen, and psychosocial issues, and long-term consequences are cardiovascular disease, obesity, type 2 DM, cancer, and death usually occurs in later stages. So classification of sleep disorders. Sleep disorders are classified into various categories. One is parasomnias. Parasomnias, that is in REM sleep disorders, REM sleep behavior disorders, that is nightmares usually occurs. In NREM sleep disorders, sleepwalking, sleep terrors, and confusional arousals are seen. In category of sleep breathing disorders, obstructive sleep apnea, obstruct in NREM sleep disorders also obstructive sleep apnea is seen. Other disorders, narcolepsy and sleep paralysis usually seen in REM sleep disorders. NREM sleep disorders, insomnia and disorders of arousal is usually seen. So DSM, based on DSM-5 classification, there are various sleep disorders. That is one is insomnia disorders, hypersomnolence disorders, narcolepsy, breathing related disorders, obstructive sleep hypopnea, central sleep apnea, sleep related hypoventilation, circadian rhythm, sleep wake disorders, and parasomnias, non-REM sleep arousal disorders, nightmare disorders, and REM sleep behavioral disorders, restless leg syndromes, and substance or medication induced sleep disorders. Certain medications and substance can also induce sleep disorders. Example, increased smoking, increased consumption of alcohol, okay, and other narcotic substance can also hinder sleep. So, based on ICD classification, there are non-organic sleep disorders and organic sleep disorders. In non-organic sleep disorders, in ICD-10 is classified under F51.0, that is non-organic insomnia, and F51.1 is non-organic hypersomnia, and F51.2 is non-organic disorders of the sleep-wake schedule, and F51.3 is sleep waking, that is somnambulism, and F51.4 is sleep terrors, that is also known as night terrors. F51.5 is nightmares, and F51.8 is other non-organic sleep disorders. F51.9 non-organic sleep disorders, that is unspecified. Even certain unspecified things can also cause sleep disturbance. So now we talk about insomnia. What is insomnia? Insomnia is defined as a difficulty in initiating or maintaining the sleep. That is usually called as insomnia. Inability to switch off arousal related circuits. Most common complaint is come from all patients is I am having insomnia. I have sleep disturbance. Okay, the prevalence is 30 to 45%. Maybe transient or persistent. Sometimes it may be transient. Sometimes patient have insomnia, and sometimes patient usually sleeps well, and that's called transient. Persistent means usually throughout every week, holidays, or years, they will have persistent have insomnic symptoms. So the diagnostic criteria of insomnia, that is predominant complaint of dissatisfaction with sleep quantity or quality associated with one or more of the following symptoms. One or more of the following symptoms is given below should be present, which should affect both quantity and quality of the sleep. The one is difficulty in initiating sleep. In children, this may manifest as a difficulty initiating sleep without caregiver intervention. Next is difficulty maintaining sleep, characterized by frequent awakenings. In between patients usually awakening during the night multiple times, or problems returning to sleep after awakening. Sometimes even if they wake up, they will be difficulty in going back to sleep. Okay, in early morning awakening with inability to return to sleep. Some patients will wake up early in the morning, but after some they go back to sleep, they won't able to get the sleep. These, at least out of this, two symptoms should be present to call it as insomnia. The sleep disturbance causes clinical significant distress or impairment in social, occupational, educational, academic, behavioral, or important areas of functioning. Okay, the sleep difficulty occurs at least 3 nights per week. So, out of those three and ABC, two should be present. Okay, to call it as a insomnia. So, sleep the difficulty should be seen at least 3 nights in particular week. Okay. Then sleep difficulty is present for at least 3 months. Okay. The sleep difficulty occurs despite adequate opportunity for sleep. The insomnia is not better explained by and does not occur exclusively during the course of another sleep-wake disorder, especially narcolepsy or breathing related sleep disorder or circadian sleep disorder or parasomnias and other disorders. And the insomnia should not be contributed by drugs and medication or any coexisting mental disorders or medical condition should not cause this sleep problem. Then we call it as insomnia. So insomnia based on ICD-10 criteria, the following are essential clinical features for definite diagnosis. The complaint is either difficult falling asleep or maintaining sleep or a poor quality of a sleep. B is the sleep disturbance has occurred at least 3 times per week for at least a month. So in DSM, at least for 3 months and 3 times per a week. There's a preoccupation with sleeplessness and excessive concern over its consequences at night and during the day. Usually they will be preoccupied that they are not sleep properly during the day. During office time, they will be preoccupied. I am not didn't sleep properly. That's my sleep is not adequate and quality of the sleep is not adequate to me. Okay, that preoccupation is usually present. Okay, the unsatisfactory quantity or quality of sleep either causes marked distresses or interferes with the ordinary activities in daily living. So, because of this unquantity and poor quality and poor quantity of sleep, patients can't able to do their daily routine activities. It always interferes with their daily routine activity, like going to job is very difficult for them. They can't able to drive a car, a bike to commute to the job, or it causes very much distress that morning works they can't able to concentrate in particular to the jobs which is they are assigned. So how to manage pharmacological management of insomnia? So one primary insomnia usually treated by benzodiazepines. Examples like zolpidem, zolpidem, short-acting drugs like zolpidem for initial insomnia, melatonin receptors agonists like remaltion for sleep onset insomnia, and long-acting like clonazepam, clonazepam for middle insomnia. Usually, and sedating antidepressants or trazodone are prescribed as sleep aids. Okay, antihistamines can be also be prescribed. Protein precursors like L-tryptophan can also be given. So, cognitive behavior therapy can also be tried to deconditioning for difficulty in initiating. So, sleep restriction therapies, which increases the sleep efficiency by decrease the amount of time spent awake in bed. When sleep restriction is efficacy is 85%, average 5 nights time in a bed increases by 15 minutes. It produces a gradual decline in nocturnal awakeness. And relaxation therapies can like self-hypnosis, progressive relaxation like JPMR exercises, guided imagery, and deep breathing exercises are effective in producing relaxation, which in turn treat the insomnia. So, the biofeedback used to measure the muscle tension in forehead and finger temperatures. Okay, cognitive training can also be improves in sleep insomnia, and paradoxical intentions can also be tried. So, recent advances in treatment of insomnia are dual orexin receptor agonists, that is DORAs, and suvorexant and lambroxant and dodirent and celetorexant can also be given. So, now we come to hypersomnolence disorders. Hypersomnolence is an excessive quantity of sleep and drowsiness with reduced vigilance during usual periods of wakefulness. It is a mere opposite of insomnia. So it is a relatively rare condition. Failure usually causes failure at school, loss of employment, multiple motor vehicle accidents, and industrial disasters can also occur in hypersomnolence disorders. So based on DSM-5 or the diagnostic criteria is self-reported excessive sleepiness, hypersomnolence despite a main sleep period lasting at least 7 hours with at least one of the following symptoms. So recurrent periods of sleep or lapses into sleep within the same day. So usually patient will have multiple lapses of sleep, a prolonged main sleep episodes of more than 9 hours. Usually patients sleep more than 9 hours per day. That is non-restorative. That non-restorative means usually even after 9 hours of sleep, the patient doesn't feel refreshing after waking from the sleep. So difficulty being wakeful after abrupt awakening. So patient has very difficult even after you vigorously or try to wake the patient, they will have difficulty in awakening. So next is hypersomnolence occurs at least 3 times per week. So even in insomnia, international at least 3 times per week, and in hypersomnolence also should occur 3 times per week for at least 3 months. The hypersomnolence is accompanied by significant distress or impairment in cognitive, social, occupational, and other importance areas. Okay, these are also should be affected. During hypersomnolence is better explained by and does not occur exclusively during other causes of another sleep disorder. Another sleep disorder should not be present to call the hypersomnolence disorders. The hypersomnolence is not attributable to physiological effects of substance. So substance or abuse or medication should not cause hypersomnolence disorders. Example like using of benzodiazepines, patient complaining of hypersomnolence, it doesn't mean patient is diagnosed with hypersomnolence disorders. So coexisting mental disorders should also be ruled out before categorizing the patient with hypersomnolence disorders. So Clingy-Levin syndrome. So Clingy-Levin syndrome is the recurrent periods of prolonged sleep from which patients may be aroused with intervening periods of normal sleep and alert waking. So episodic hypersomnolence affects young men, that is between the age of 10 and 21. At least two diagnostic criteria of Clingy-Levin syndrome is at least 2 recurrent episodes of excessive sleepiness of 2 days of to several weeks. So episodes recur at least once every 18 months, or normal alertness, cognitive function, behavior, and mood between episodes. At least one of these during an episode, a cognitive dysfunction, altered perception, or derealization, hypophagia or hyperphagia should be present, or disinhibited behavior or symptoms cannot be better explained by any other condition. And only we can diagnose this syndrome. So in this, amnesia follows attacks may resolve spontaneously after several years. Treatment is stimulants like amphetamines, methylphenidate for hypersomnia, or other preventive measures like lithium also may be used successfully. So menstrual related hypersomnia, recurrent hypersomnia episodes related to menstrual cycle with intermittent hypersomnia episodes are before or menses onset. Sometimes it occurs before or during the onset of menses. Symptoms last for just a week and resolve within after the menstruation is over. So the treatment is oral contraceptive pills is effective since it is secondary to hormonal imbalance. So another is idiopathic hypersomnia. So long sleep periods with patient remains sleepy. The sleep well preserved and sleep efficiency is increased with extended sleep schedules less more than 12 hours. Etiology is unknown, but categories are subgroup 1 HLA, CW plus positive and ANS dysfunction and affected family. Subgroup 2 is post-viral infection like Guillain-Barré syndrome, mononucleosis, atypical viral pneumonia, and subgroup 3 non-familial and non-post-viral, truly idiopathic in nature. So idiopathic hypersomnia usually occurs in the age onset of 15 to 30 years, associated with long non-refreshing nap, difficulty awakening, sleep drunkenness, automatic behavior with amnesia, migraine-like headaches, fainting spells, syncope, orthostatic hypotension, and Raynaud's type phenomena with cold hands and feet. Usually, the treatment is modafinil. That usually ranges between 100 milligram, 50 to 100 milligram. Modafinil can is the first line of treatment. Or traditional psychostimulants like amphetamines can also be tried. So hypersomnia due to medical condition. Certain medical condition can also lead to hypersomnia. Though these are a trauma, stroke, encephalitis, Parkinson disease, inflammation, tumor, genetic and neurodegenerative diseases like treatment which is the treatment is modafinil. That is also first line drug. And the amphetamines also can be tried in hypersomnia due to medical condition. So hypersomnia due to drug or substance use. So these hypersomnia usually caused by other sedative drugs like hypnotics, amphetamines, antidepressants, anti-epileptics, neuroleptics, opioid analgesics, or withdrawal from stimulants like cocaine, amphetamine, caffeine, nicotine, etc. So what is narcolepsy? Narcolepsy has an incidence of 0.02 to 0.16% of adults as narcolepsy and shows some familial incidents. So usually they have familial incidents more. Occur at any age, most frequently in adolescence or young adulthood. Less than 30 years is the commonest age of occurring of narcolepsy. Narcolepsy has sleep attacks, episodes of irresistible sleepiness, 10 to 20 minutes after which feels refreshed. Occur at inappropriate times. So inappropriate time, usually they have attacks of sleep that lasting for 10 to 20 minutes, after which the patient feels refreshed. Okay, that is narcolepsy, which has also has excessive daytime sleepiness, cataplexy, sleep paralysis, unable to move on awakening, or hypnagogic hallucination. These are the so cataplexy, that is sudden loss of muscle tone, jaw drop, head drop, weakness of knees, paralysis of skeletal muscles with collapse, caused by emotions or seconds lasting 2 minutes. Suddenly, while walking, the patient will sudden loss of muscle tone, suddenly drops on, fell down. Okay. Or sometimes while doing work, suddenly the patient falls down to the desk. Okay. That's how cataplexy, sudden loss of muscle tone. But the patient doesn't have any other neurological condition like stroke or any cardiac arrest, nothing will be there. Only there will be sudden loss of muscle tone for which may be lasting for 10 to 15 minutes. After that, patients will be waking. Appearance of REM within 10 to 15 minutes and normal 90 minutes seconds of sleep onset is evidence of narcolepsy. Progresses slowly or reaches a plateau that is maintained throughout the life. So the diagnostic criteria: recurrent periods of irrepressible need to sleep, and lapsing into sleep, napping occurring within the same day. Multiple times they will be go back to lapsing of sleep, like lasting for 15 to 30 minutes, must have been occurring as a at least 3 times per week over the past 3 months. So the presence of at least one of the following criteria are episodes of cataplexy defined as either A or B are occurring at least few times per month. An individual with long-standing disease, brief seconds to minutes, episodes of sudden bilateral loss of muscle tone with maintained consciousness. The patient will have consciousness, but there will be sudden loss of muscle tone that are precipitated by laughter or joking. Usually, after there will be after vigorous laughing or joking, patient might have cataplexy-like symptoms. In children or individuals within 6 months of onset, spontaneous grimaces or jaw opening episodes with tongue thrusting or a global hypotonia without any obvious emotional triggers. And hypocretin deficiency as measured using a cerebrospinal fluid, CSF fluid, hypocretin 1 immunoreactivity values gives a less CSF levels of hypocretin 1 must not be observed. So, in the context of acute brain injury, inflammation or infection should be ruled out. So, nocturnal sleep polysomnography should be studied, showing rapid eye movement, REM sleep latency less than or equal to 15 minutes, or multiple sleep latency tests showing a mean sleep latency less than or equal to 8 minutes and 2 or more sleep onset REM periods. So types of narcolepsy or narcolepsy with cataplexy or hypocretin deficiency, narcolepsy without cataplexy, or either without hypocretin deficiency or hypocretin unmeasured, or narcolepsy with cataplexy or hypocretin deficiency due to a medical condition, or narcolepsy without cataplexy and without hypocretin deficiency due to medical conditions. So treatment are modafinil, amphetamines, methylphenidate, gamma hydroxybutyrate, sulfamycetol, or and other drugs. REM sleep suppressing drugs like antidepressant, imipramine, SSRI, fluoxetine can also be tried. So now we'll sleep about OSA. So due to cessation of airflow through the nose or mouth in the presence of continuing thoracic breathing movement results in decreased atrial O2 saturation and transient arousal, after which respiration resumes normally. Occurs in the middle-aged overweight men and in patients with smaller jaws, like also called known as micrognathia, retrognathia, nasopharyngeal abnormalities, acromegaly, and hypothyroidism patients also develop OSA, obstructive sleep apnea, sleep disorders. Okay, symptoms are slow, loud snoring, daytime sleepiness, sleep attacks, nocturnal awakening with choking, gasping or breathe, morning dry mouth, morning headaches, heavy nocturnal sweating, and morning confusion can also be seen. The consequences are cardiac arrhythmia, systemic pulmonary hypertension, and decreased sexual drive, or erectile failure in men, nocturia, polysthymia, depression, anxiety, and memory impairment also seen in this kind of patients. So polysomnogram, multiple periods of more than 10 seconds in which the nasal and oral airflow ceases completely. That is apnea occurs, and partially hypoapnea while abdominal and chest expansion leads indicate containing efforts of diaphragm and accessory muscles of respiration to move air through obstructed airway. So apneic events occurs in REM more severely than and more frequent in NREM 1 and 2. Okay, patients are unaware of the episode. Usually, patient doesn't know the awareness, doesn't have the awareness about this episodes. So, treatment of OSAs or positive airway pressure PAP or BiPAP can also help. Okay, and oral appliances like snoring and appear beneficial for mild and moderate OSAs. Sleeping on back like tennis balls fan placed in pockets on the back of night shirt foam wedges, which also has a beneficial results. Drugs like medroxyprogesterone acetate, TSAs, theophylline, mirtazapine, serotonin, epinephrine compounds improve breathing. Wake promoting substances like modafinil for treating residual sleepiness. So treatment is one is weight loss, surgical intervention to correct airway obstructions and other malformation, and UPPP, that is uvulopalatopharyngoplasty, which studies suggest modification of soft palate efficiency relieved most sleep apnea. There is 30 to 50% benefits from UPP. If obstruction is posterior airway upsave, pass can be done. So now we read about sleep related hypoventilation. Idiopathic hypoventilation patients have normal lung and decreased alveolar ventilation, resulting in sleep related atrial O2 desaturation. So polysomnography reveals episodes of shallow breathing more than 10 seconds associated with atrial O2 distraction, desaturation, and frequent arousal from sleep associated breathing disturbances and brady or tachycardia. Patient has excessive daytime sleepiness and insomnias. Some congenital central alveolar ventilations, that is on-the-name cross, can be present at birth, and hypoventilation due to failure to automatic control of breathing. Treatment is continual ventilatory support. The comorbid sleep-related disorders of hypoventilation or hypoventilation consequences of medical conditions like pulmonary parenchymal disorders, vascular pathology, lower airway obstruction, neuromuscular, and chest wall disorders can also lead to these hypoventilation disorders. So, circadian rhythm sleep disorders are involves misalignment between desired and actual sleep periods. Etiology is desynchrony between individual internal circadian biological clock and desired conventional sleep wake cycle. So usually all human beings have the circadian rhythm. They have a biological clock which makes them whenever we wake at the morning. Usually it's because of our biological clock. When it is disrupted, it disrupts the circadian rhythm of and causes sleep disorders. Okay. So the circadian pacemaker located in SCN and oscillates in sinusoidal pattern and periods of 24 hours and output correlates with daily fluctuation in core body temperatures. The circadian pacemaker reset by bright light, social cues, stimulants, and activity. So sometimes continuous bright lights can also affect the circadian rhythm and social cues. Some social works or some important things can also affect. And stimulants like alcohol, nicotine, or cocaine, those can also affect the circadian pacemakers. So DSM lists the 6 types of circadian rhythm sleep disorders. One is delayed sleep phase type, that is biological clocks run slower than 24 hours and shifted later than desired schedule. Phase delays in sleepiness, alertness cycle. This night owls cycle, alert in evening and early night time, stay up late and tired in the morning. Advanced sleep phase types are circadian rhythm cycle is shifted earlier in advance with respect to clock time. Early bird larks, also called as drowsy in the evening, sleep awaken earlier, alert in the morning. Irregular sleep wake type, in which the irregular sleep wake pattern absent or pathologically diminished circadian sleep wake rhythm and patients has normally amount of sleep during 24 hours period but fragmented into more than 3 episodes of irregularity. Symptoms of insomnia, night or excessive sleepiness, daily life are significantly impaired associated with neurodegenerative disorders like Alzheimer's can also seen and neurodevelopmental disorders in children. So non-24 hour sleep pattern, free running, that is increased cycle 24 hours does not reset each morning. Normally desynchronization of circadian rhythm occurs daily in the response to the light dark cycle. The sleep problems peak when circadian and environmental clocks are 12 hours out of phase and begin to lessen progressively resolving in advanced sleep phase. So eventually clock correlates and sleep wake cycle is normal for a few days, after which insomnia, hypersomnia cycle begins. Again, periodic insomnia and periodic excessive sleepiness are usually seen. Common in blind are visually impaired. So these are usually seen in commonly blind people and visually impaired people. The traumatic brain injury TBI associated with non-24 hour sleep wake type treatment is phototherapy and melatonin. The shift work type 24 hours operation transportation like healthcare people are affected. They have a shift work type of difference. So it is insomnia circadian rhythm is usually disrupted. Shift workers like causes insomnia or excess sleepiness of both. Some adjust and the others have difficulty. The result is profound sleep deprivation. A natural low point in normal sleep wake rhythm occurs at approximate 3 to 5 a.m. Transportation and industrial accidents usually occurs during this time 3 a.m. to 5 a.m. So jet lag type usually occurs in the people who are traveling from one continent to the other continent. When travel across many time zones, circadian phases advances and delays is induced. So frequent travelers find quite impaired at making decisions. Sometimes it also affects the decision making skills. So night owls difficulty adjusting to the eastward travel because desynchronization requires phase advance. Okay, and larks difficulty with westward travel. So night owls usually have difficulty in adjusting with eastwards. Night larks usually have difficulty in westwards. Okay. So due to medical conditions, sleep circadian rhythm disorders due to any other medical condition like bedridden patient, hospitalized dementia patient, chaotic sleep wake and pattern affecting the circadian rhythm. The sleep in ICU is disturbed by noise, light, therapeutic monitoring procedure performed because in ICU sometimes patient and other patient will be very sick. Rather than doctors have to attend or staff nurses, there should be light, adequate sugar, patient serve visibility. So this also affect their sleep patterns and significant sleep disorders can also be caused. The abuse of recreational stress drugs like methamphetamine associated with individuals remaining awake overnight or continuously for several days at times. Profound hypersomnia like crashing can be seen. The treatment of circadian rhythm disorders are chronotherapy, and light SAR phototherapy can also be used for this kind of disorders. Treatment of circadian rhythm. Usually, melatonin can be prescribed. Synthetic melatonin is remoletin can be given. Wake promoting hormones like modafinil can be if the patient has excessive sleepiness or can given out. And parasomnia disorders, partial arousal sleep disorder, characterized by physiological behavioral phenomena that occurs during potentiated by sleep, parasomnias, and NREM sleep arousal disorders. The sleep waking somnambulism usually arises from the bed ambulates without fully awakening, begin at the 1st and 2nd with slow wave sleep episodes. With the sleep deprivation and interpretation of slow wave sleep exaggerated and excluding sitting up and attempting to walk, sequence of semi-purposeful action, interact with the environment, avoiding tripping over the object, and track inappropriate stepping out of the window, walking into the hallway. They are difficult to awaken. Once awake, it will be confused. People will have confusion if after awakening in kind of somnambulism patient. In adults, it is a rare as a familial pattern, usually seen in multiple families. If patient has somnambulism, it has a higher chances of presenting in the patient. It occurs as a primary insomnia or secondary to another sleep disorders like sleep apnea. Common in children up to 4 to 8 years. After adolescence disappears spontaneously. So sleepwalking, sleep related. Sometimes patients have episodes of ingesting food during the sleep without varying degrees of amnesia. There isn't amnesia won't be seen, but they will be eating low. Sexomnia or sleep-related sexual behavior. When person engaged in sexual activity, that is masturbation, fawning, sexual intercourse during sleep without consciousness awareness. Sometimes patients during sleep they will be masturbating themselves or do sexual intercourse during sleep without a consciousness awareness. They won't have a conscious awareness of sleep. So sleep terrors or on night terror, the first third of during NREM arises from slow wave sleep, sudden arousal or intense fearfulness, piercing, screaming cry, or cry behavioral manifestation, intense anxiety, bordering panic. No signs of TLE, other seizure disorders seen clinically on EEG recordings. Sits up in the bed, unresponsive to stimuli, in fake, now confused or disoriented. Vocalizations present, incoherent amnesia or episodes are present. Fever, CNS depression, withdrawal, sleep depression, or sleep terrors. Severity ranges from less than 1 month to almost every night, injury to the patients or others. Parasomnia associated disorders, recurrent isolated sleep paralysis, inability to make voluntary movement during the sleep, lost occurs, and feature of REM sleep. Briefly, introduction wakefulness is sleep. Improved treatment is improved sleep hygiene and assurance of sufficient sleep. Nightmare or dream anxiety attacks are usually seen in with condition, frightening and terrifying dreams. Ultimately, awakening occur in REM sleep. Remembers dream like unlike sleep terrors. Some are recurrent in association with PTSD, common in 3 to 6 years and rare in adults, results in insomnia and it usually separate to sleep deprivation. Because of this, sleep deprivation causes and exacerbate it. So night terror, nightmare usually because of nightmare, patient doesn't afraid to go to sleep, and because of this afraidness, the sleep deprivation occurs and it's exacerbate the insomnia. So it's usually seen in schizotype, borderline schizoid personality disorders or at high risk. L-DOPA, beta adrenergic blockers withdrawal, or REMS suppressant drugs, alcohol abuse induces nightmares. So levodopa, those things also cause nightmares. Management, universal sleep hygiene, stimulus control therapy, lucid dream therapy, cognitive therapy. In nightmares related PTSD, nafazadone can also be tried, and prazosin can also be used. Increase the total sleep time on REM sleep time. Benzodiazepine may be also be helpful. So difference between sleep terror and nightmare is timing during the night. First, that is deep slow waves. Nightmare last REM sleep. Moments common, rare. Nightmare moments is rare. Sleep terror common. Severity severe. Nightmare mild. Vocalization common, rare. And autonomic discharges severe and intense. Mind and nightmare it is mild. Amnesia absent in sleep terror. Amnesia is present in nightmare. So state on awakening, confused, disoriented, nightmare function well. Injuries common in night terror, nightmare rare. Violence common and nightmare it is rare. Displacement from bed is common in night sleep terror and it is very rare in nightmare. The sleep paralysis, that is bedwetting primarily or secondary After a toileting, training, bedwetting, spontaneous resolve within 6 years. If it lasts more than 6 years, it is called enuresis. If it is a defecation, it is encoparesis. The sleep-related groaning, that is catharrhenia, that is chronic groan frequency. Loud groans during sleep can occur in any sleep stages, begin during childhood. Polysomnography with respiratory sounds, monitoring sound during exhalation, and respiratory dysarrhythmias. No known treatment doesn't improve with CAP therapy. Sleep cluttered hallucination, visual images of sleep onset awakening, hypnopompic. That is whenever awakening time, if you have hallucination, it is hypnopompic. Hypnagogic is during sleep. Okay. Which has vivid immobile persists for several minutes, disappears when the light is turned on. So these are type of hallucinations are common and it is normal in physiological phenomena. Sleep related eating disorders are inability to get back to sleep after waking unless they eat or drink. Common in infants and children, rare in adults. In adults, nocturnal eating can be continued through awakening. Eating may become obsessional. Patient may be unaware of activity and weight gain. Can become a problem. So now we sleep related movement disorders. So uncomfortable subjective sensation of limbs, usually legs, sometimes described as a creepy crawly feeling, irresistible urge to move legs and when at rest while trying to fall asleep. Okay, this is called restless leg syndrome or egg bomb syndrome. Was at night and moving legs or walking elevate the discomfort results in profound insomnia. So uremia or neuropathy is iron deficiency, iron and folic acid deficiency can produce secondary restless leg syndromes and associated with fibromyalgia, rheumatoid arthritis, diabetes, thyroid disease, or COPD can also increase restless leg syndrome. And dopaminergic agonists, treatment is dopaminergic agonists like pramipexole, propinerol, dopamine precursors like levodopa, benzodiazepine, opioids, and anti-epileptic drugs are like gabapentin can also be used. Non-pharmacological treatment are avoid alcohol use to close to bedtime, massaging affects the parts of the leg, taking hot baths, applying hot and cold to affected areas, engaging in moderate exercises. So periodic line movement disorders or nocturnal myoclonus. It is a brief, stereotypic, repetitive, non-epileptiform movements of the limbs occurs in NREM sleep involves in extension of big toe partial flexion of ankle knees, lasting for 0.5 to 0.5 seconds occurs every 30 to 40 seconds. Observed with brief or self treatment is dopaminergic agonist and benzodiazepine. Anti-epileptics drugs like gabapentin can also be tried. Thank you. So now we finish about sleep disorder. Thank you very much, my dear students.